Hi, I'm Jessica Templer. I'm a neurologist and an epileptologist at Northwestern University Feinberg School of Medicine. I'm the director of the tumor-related epilepsy program, and I'm involved with the low-grade glioma program. Today, I'll be speaking about the approach to focal epilepsy secondary to dominant temporal low-grade gliomas. I have no disclosures related to this talk. In terms of learning objectives today, I would like to help you understand the approach to patients with epilepsy secondary to a suspected low-grade glioma, and in addition, identify appropriate candidates for intraoperative ECoG and awake craniotomies. So to give you an overview, I'll be briefly discussing terminology, in addition to an algorithm as an approach to patients with low-grade gliomas, and to highlight this approach with a case of intraoperative ECoG with a suspected low-grade glioma in the dominant temporal lobe. To begin, I would like to briefly review the terminology regarding low-grade gliomas. In the WHO 2016 classification, the term mixed oligoastrocytoma was removed. And now WHO grade 2 diffuse gliomas are categorized into diffuse astrocytoma and oligodendrogliomas, and further categorized by the IDH mutation status. The majority of low-grade gliomas will be IDH-mutated oligodendrogliomas and diffuse astrocytomas. Seizures are more frequently seen in patients with IDH-mutated tumors. Case number one, the history is this is a patient with a 32-year-old right-handed man presenting with focal seizures. The semiology prior to surgery, he had two primary types. One was episode of speech arrest, followed by right hemiparesis, lasting for about 1 minute. Type 2 were right leg sensory symptoms that would then progress up his trunk, rarely to his right upper extremity. He had no prior EEGs, and he was on levetiracetam 1,000 milligrams BID. Here is his preoperative MRI. As you can see, there is an expansile flare hyperintense mass involving the left insula, left external extreme capsules, left corona radiata, and left anterior superior temporal lobe. In the axial plane, the lesion measures approximately 6.5 by 2.3 centimeters. In 2013, an algorithm was published in Epilepsia by Reims, Ducret, and Rivlin, highlighting the approach to patients with tumor-related epilepsy. Suspected high-grade gliomas should be taken for a maximal possible resection as soon as a high-grade lesion is suspected. Now, with regards to WHO grade 1 lesions, such as glioneuronal tumors, the timing and approach to surgery is a question of whether epilepsy surgery is appropriate for the patient, really highlighting the importance of the epilepsy history and driving the decision-making with grade 1 tumors. If it's unclear whether the lesion is focal cortical dysplasia or a low-grade glioma, and the patient's epilepsy is easily controlled, a repeat MRI in 3 months may be warranted. If there is a high suspicion for a low-grade glioma based on initial imaging, for example, if the lesion appears expansile, early surgery would be recommended. In summary, these cases can be somewhat challenging when considering when to take the patient to surgery, although often early surgery is recommended with a maximal possible resection within functional boundaries. In addition, ECoG may be considered. Most importantly, what we want to focus on is the quality of life in addition to overall survival and obtaining a pathologic diagnosis. For this, we want to do a maximal possible resection using preoperative and intraoperative workup to reduce the risk of postoperative deficit. This often means considering ECoG. Here's an example of this patient's preresection ECoG. So in our patients, we typically will do preresection ECoG before any awake craniotomy to ensure there is no ongoing seizures, putting the patient at risk for further seizures during mapping. In addition, this can help guide surgery for these patients. So I used a 2x5 grid overlying the tumor, as you can see oriented here. Here is the intraoperative ECoG, and again, this is prior to any stimulation. And you can see contact 1 wasn't here because it didn't have good contact with the cortical surface. But here you can see repetitive discharges primarily surrounding contact 3. Here's where the repetitive discharge is localized to. Here's the intraoperative grid in relationship to the cortical mapping points. So as you can see, we were able to locate language as well as motor function as labeled here on the side. It's important to note that this patient's lesionectomy was guided by awake mapping results, but also we could say that we should try to include the areas in context 2 and 3 where his epileptiform discharges were, although he was unable to have his cortical mapping points, the area surrounding the cortical mapping points, resected. An important point about this case is that awake mapping was able to be completed by avoiding stimulating the cortical surface, generating repetitive discharges. So importantly, we could identify Wernicke's without provoking any seizures during surgery. Here, just to highlight, so this is the ECoG artifact that's associated with cortical stimulation. And you can see the repetitive discharges continued. And while he was mapping the area posterior to this region, he could continue without provoking any seizures. Without ECoG and recognizing this early on in the surgery, perhaps he would have provoked a seizure and been unable to complete the awake mapping that was required for this patient. Here is his postoperative MRI. So the path was consistent with a WHO grade 2 oligodendroglioma, and the patient has been seizure-free for 3 years. Another perspective on the approach to low-grade gliomas was reported in 2017 by Kim. A total of 48 adults presented with low-grade gliomas, although it's important to note that this included both grade 1 and grade 2 lesions. Outcomes were evaluated based on whether the patient presented to the epilepsy service or the neurosurgical service. Angle class 1 outcomes were significantly more frequent seen in patients who were admitted to the epilepsy service. As you can see here, it was 88% compared to 46%, suggesting there is a potential benefit to involvement of the epileptologist in these cases. It is important to note, though, that the neurosurgical service had a significantly greater number of patients with grade 2 lesions, which may in fact have been more difficult to render seizure-free postoperatively. However, a remarkable finding from this study was the time from first seizure to surgery. Among the patients followed by the epilepsy service, the duration was 30 months compared to 0.5 months, suggesting that patients were taken immediately to surgery when initially seen by the neurosurgical service. Many questions remain as to how we can explain the different outcomes in terms of seizure freedom among the two services. However, the results really highlight the need for our epilepsy and neurosurgical services to collaborate and bring the patient to surgery within a reasonable time frame, but also integrating the diagnostic testing and interpretations that we have available to offer the best possible outcome for our patients with low-grade gliomas. I hope in the future this will help you consider intraoperative ECoG for patients undergoing a suspected low-grade glioma resection. And just to keep in mind that an awake craniotomy is the gold standard when functional mapping is necessary for a low-grade glioma resection, and you often are not able to answer all the questions that you need answered with just a functional MRI. Here are some references. And thank you very much. Here is my contact information in addition to the website, which leads you to our Northwestern Medicine low-grade glioma program, where we offer comprehensive care for these patients with neurosurgery, neuro-oncology, and myself in the epilepsy division. Thank you.